So hello, I'm Kristina Mirabeau Beale. I'm a practicing radiation oncologist in Southwest Florida, where I do mostly breast and GYN and palliative radiation with 21st Century Oncology, now newly rebranded as Genesis Care USA. Um, so I'm really excited about this meeting, um, the content we're trying to present. Um, but I was really nervous and anxious about doing this topic in particular. So I've been tasked with discussing equality and equity in medicine and to discuss the Black experience. And obviously, it's been a very kind of troubling time in the world, in our country. And this is a very near and dear topic to me. And it's one that's, very sensitive and emotional. So I'm going to just I have one voice and I hope to add it to some of the discussions. And I wish we could do meetings like this more in person, just because I think kind of the interaction, sharing personal experiences is so important. But I'll do my best to try to shed light on some issues in cancer care and disparities, particularly focusing on the Black experience. So, I wanted to begin by showing this image because it is a nod to many recent events. So depending on where you live in this country, depending on kind of your personal lens, your personal experience, what are the terms, Black Lives Matter mean? What is the significance of hearing things like we are in a post-racial America? What does the time 8 minutes and 46 seconds, mean to you? And, there are a lot of very intense, very negative social justice experiences that have been unfolding. And even though my practice is in radiation oncology, where I focus on using, radiation to cure cancer, I'm also a woman. I'm also a wife to an African-American man. I'm also a mother to two young Black boys. And a lot of these issues very much affect me, my family, my perspective. And then also, as I hope to make the case, during this presentation, also cancer care. So I wanted to begin with a few cases because sometimes, especially, my lens as a cancer doctor, it's helpful to kind of think of some people. So, taking a step back, Miss MC is a 65-year-old Haitian woman in my practice, and she doesn't speak English. And she was diagnosed with a triple positive early breast cancer. She lives with her daughter, and she also lives with her son-in-law, and has very limited literacy. And it actually took this woman almost a year to get to surgery, just due to issues with transportation, kind of understanding the importance of the different modalities of treatment. By the time I finally saw her to do radiation, she'd had breast conserving surgery and needed radiation. It was very tough to get her to comply with the daily treatments required. And so we had to do a lot of work with our patient navigators, et cetera. And so, her case definitely brought to light a lot of issues with compliance, health literacy, cultural competence in its own way. Another case, Miss GJ, so she's an African-American woman, she was young, she was 43, is 43, and she had a very tiny screen-detected triple negative breast cancer. And she's highly educated, she works as a teacher in our school system. She's very, very motivated to get back to work, especially because her work as an educator and during this pandemic, in terms of just organizing programming for the students, she's very connected to our community. In a sense, she ended up prioritizing a lot of that social justice warrior work more so than her own health. And she actually had an unfortunate interaction with her medical oncology office where due to some somewhat insensitive comments made, she basically said, "I will never have chemo." And this is a young woman who has very curable but very aggressive breast cancer that's triple negative, where standard of care is to involve chemotherapy. And we went through many iterations and we're not able to kind of bridge that gap once that distrust was laid. But she was very motivated to not miss a single day of work, and a lot of kids in our community are benefiting from her activism and work. But her case, her experience, unfortunately, in navigating medicine really resonated with me. And then another case, this is a gentleman actually, he's Afro-Latino, works in construction, long history of ortho issues. He's a very physical guy, very athletic. Previously, zero primary care, manly man, guy's guy, doesn't believe he ever needs to see a doctor unless something's really bad. But interestingly, in one of our community endeavors, um, he kind of just had a screening PSA as part of our awareness campaign. And unfortunately, he came back very elevated. So PSA was 49. That led him to enter medical care for the first time, really. Ended up having a high-risk prostate cancer with Gleason 8 disease. And as I started kind of guiding his workup, unfortunately, his initial scans showed he actually had metastatic disease at presentation. Um, and in navigating this with his family, it was very much like, well, how did this happen? We blinked from being perfect to not. Um, and again, a lot of issues with mistrust, um, in the medical system. And just, I think these three cases kind of illustrate different facets of kind of what can be one aspect of the Black experience in cancer care. And just some different, examples of individuals to kind of keep in mind as we have a charged discussion like this, like who are we referring to? What are we thinking about? What are some of the things we need to address? So, not more broadly, like now that we've addressed some of these kind of clinical situations, some general thoughts. So, the literature is actually really full of a lot of descriptive statistics showing higher incidence and mortality for Blacks for many health conditions. And cancer is obviously no exception. And often we discuss that the root of healthcare disparities is very multifactorial. But I think it's so important that we really acknowledge that racism is part of this equation. And it's really imperative for us moving forward to address this. So, what is racism? Different definitions, but one we can start with today. So think of it as organized systems within societies that can cause avoidable and unfair inequalities in power, resources, capacities, opportunities, kind of across racial or ethnic groups. And this can manifest itself through beliefs or stereotypes or prejudices or discrimination. And, there's really multiple levels. Um, there can be internalized racism in different belief systems. A lot of cultures, especially in kind of like the post-colonial world, do internalize a kind of legacy of, um, you know, supremacy or inferiority that is so rooted in the paradigm of a lot of day-to-day interactions that we often take it for granted. My family is, kind of multiracial from the Caribbean. And, there's a lot of dialogues about complexion and things that often we don't address, but unfortunately can actually play out in really complex personal interactions that then, when they're extrapolated to a bigger situation, such as one's interactions with the healthcare system, and especially around something as intense as cancer care, unfortunately can play out. Obviously we're used to thinking about kind of interpersonal racism at times, interactions between individuals. Um, and then of course there's systemic racism, things like systems of oppression that affect large groups of people. And I think each of these levels are often interrelated. And it's important to kind of give each of them some attention if we truly want to break down these barriers and really understand what is this Black experience and how can we make it better. So I wanted to spend some time talking about Henrietta Lacks and her HeLa cells. So this is a very important story in cancer care. So Ms. Lacks was a young woman, a mother, who I think she had 5 children. And kind of shortly after the birth of her 5th child, started having some symptoms of vaginal bleeding. And she was actually seen at the Hopkins Hospital, where they took a biopsy. She then had actually an early form of radiation treatment. I'm a radiation oncologist, so she had radium treatments for gynecologic cancer. And at the time of her biopsy, some of her cells from the sample were also sent to a lab kind of across the hall. where Dr. Gray was really doing some innovative research in terms of cell culturing. And what they found were these cells from this cell line that originated from this young woman's tumor actually were continually dividing, kind of doubling every 20 to 24 hours. And this kind of fascinating cell biology allowed researchers to develop a better understanding of toxins, of drugs, of cancer pathways. Um, and this was all from a biopsy sample from this woman who unfortunately ultimately succumbed to her disease. So she passed away at 31. And like I mentioned, she was a wife, she was a mother. Um, Now, this was done, early on at the time of her death. And, this was known in medicine about her cells kind of up until even the 70s, but her family actually didn't even know about, her descendants didn't even know about the role of her cells, her biopsy in medical research till 1975, so almost like 20 years after her passing. Um, and there were a lot of landmark cases kind of surrounding this, a lot of issues of, privacy, patients' rights, intellectual property around kind of your own personal genetic material, as basically Miss Lax's, cells, her genes and her family's genetic material were used as kind of a foundational um, piece of really cancer research for a long time without appropriate recognition, um, appropriate respect for this being part of an individual's DNA, an individual's cancer journey. So there's been a lot written on her and a lot now to try to make things right. I don't know if one can ever make things right, but especially where there's a long history of, unfortunately, some abuses in medicine, particularly in the African American community. I think this is one example that's very close to home with cancer care. That can show how the patient experience can not just be mixed on the individual level, but then there can be systemic kind of abuses of power that unfortunately, leave a bad taste in the mouth of many folks, especially when it comes to uh, the importance of forming those relationships to try to attack some of these disparities in care that we have. So when we think of racism as a determinant of health, there's been a comprehensive meta-analysis that interestingly tried to synthesize a lot of the research done. So there's over 300 articles from 1983 to 2013. And racism was shown to be associated with poor mental health, including uh, depression, anxiety, psychology, and stress. And racism was linked to also poor outcomes and also poor physical outcomes as well as mental health outcomes. And they actually found that when you control for things like age, sex, birthplace, education level, none of those factors actually were able to moderate for the effect of racism on health, which is unfortunate. Um, this is an interesting meta-analysis from 2015, and it actually showed that ethnicity actually moderated the effect of racism on negative mental health and physical health. And, I think it's a lot of times, I was an anthropology major in a past life as an undergrad. A lot of times we say like, what are constructs of race, ethnicity, culture? Um, but yet they very much frame our lens that we approach the world. And by extension, live in our bodies, live our healthcare experience. So I thought it was interesting that in this particular meta-analysis, they also touched on the fact that there was a link between racism and negative mental health issues that was stronger for Asian Americans and Latinos compared to African Americans. And there was also an association between racism and physical health that was significantly stronger for Latinos compared to African Americans. And obviously, as we know, a lot of these ethnicities kind of span different racial groups, like there's Afro as well as Caucasian Latinos, and there's people who are multiracial, and the context of this discussion was more the Black experience. But I do think it's very hypothesis generating as we think of our very kind of cultural melting pot culture in the United States of different ethnicities, different nationalities, different lived experiences, and how we can come together and both acknowledge different groups' struggles to try to make the system kind of more meaningful and more rewarding for all. So, looking at cancer disparities. So this is just slides. It's older data now, 10 years old, but kind of the key take home is when we look at several different tumor types, the overall survival at 5 years is dramatically different for our white versus our Black patients. And we see an absolute difference in actual survival that's pretty dramatic across tumor types. And I'm passionate about cancer care as an oncologist, but obviously these health disparities have been shown in hypertension, cardiovascular disease, even COVID mortality. And so clearly there's something going on that we need to do better at addressing. This is a, older slide also looking at kind of the different social determinants that are likely to impact cancer treatment and outcome. And it looks at this matrix between, culture, which we've talked about, poverty, social injustice, and how these three factors can really integrate across the spectrum that we think of when we're talking about a patient's cancer journey. So whether it's from prevention and early detection, where we subsequently have kind of some degree of mistrust or even just avoidance of the healthcare systems when it comes to pursuing things like early detection and age-appropriate screening. And some of the cases I discussed earlier kind of get at this, or if it has to do with diagnosis and even pursuit of treatment, whether it's access to care, insurance coverage, inflexibility in work environment to be able to comply with, treatments. And then even the survivorship piece. So once we get our patients through treatment, their quality of life is often, permanently affected in some way. And kind of adapting with that, doing appropriate surveillance, all of these factors really come to light at every step of the journey. And kind of going deeper into these different aspects, like I said, poverty, we're talking about things like access to health insurance. A lot of patients lack a primary care physician. They lack information. There's some risk promoting lifestyles, unfortunately, being exposed to secondhand smoke, for example, living in, low income housing that may not have mold mitigation and poor, ventilation when it comes to air particles that can affect asthma and lung cancer risk. I mean, there's a lot of issues here that we're not touching if we're just focusing on the cancer in front of us and not the different multifactorial etiologies that led to the exposure that, caused the pathology. Social injustice. So whether it's perceived discrimination that sometimes can negatively affect, wanting to move forward with cancer screening, or in the case of the patient I mentioned who had a negative interaction with staff and that subsequently made her say no to chemotherapy, even though it was part of her standard of care. We also know racism is sometimes associated with cancer-related health behaviors. There can be prejudice and biases in referrals for consultations. And then kind of this other issue of culture. So, there can be issues in terms of limited health literacy. There can be issues in terms of spirituality. It's not uncommon for me to sometimes have patients who will say things like, God will take care of me. And while he will, and I, subscribe to that belief system too, I think sometimes it can make some of our patients turn away from kind of traditional medicines or listening to their team of physicians, and that can also be complicated. Beliefs and attitudes about risk-taking behaviors, medical mistrust, language barriers. I mean, there's just a lot of different issues that it would be impossible to do justice for. But I think an understanding of how these are all interrelated and can be interrelated and working together in the patient that's in front of us is just important. So when we think of, some of the more global kind of systematic inequalities and even a lot of the issues in recent news, what has been the response in the cancer community? And I don't just mean in terms of the individual patients in front of us and disparities in care there with regard to cancer mortality, but also just, even as a practicing oncologist as an individual, what have our professional societies done to try to address this? And interestingly, the American Society of Clinical Oncology, or ASCO, was really direct in its condemnation of the treatment of communities of color and really called on members to kind of confront and address complex forces and systems that have created disparities in cancer prevention, diagnosis, treatment, research, and that's great. And in a sense, it was a little disappointing that as a radiation oncologist, Astro, our professional organization, didn't have a similar kind of robust response. But fortunately, and this is kind of hot off the presses in the last month, some colleagues and mentors, as pictured here, wrote really a landmark, I think, practice-changing and really eye-opening paper that was published in Advances in Radiation Oncology in the last month called Why Racial Justice Matters in Radiation Oncology. Racial justice obviously matters in all of oncology, all of medicine, all of society. But I was really proud to be part of our field in that, like I mentioned, colleagues and mentors pictured here really use their voice to really call to action our field specifically. And I think it's very timely given the nature of our discussion today. So in this red call to action, the authors are unequivocal in their recommendation. We must place racism front and center in order to legitimately begin to work on reducing the primary risk factor for poor health outcomes among Blacks in the US. And we really need to not skirt the issue, but kind of name racism as a root of health inequality, and also acknowledging how both individual and structural racism has really affected the health disparities of Blacks in this country. So, they acknowledge that the same structural barriers that make Blacks more susceptible to COVID-19, so things like endemic poverty, poor access to quality education, healthy nutrition, inequalities in the healthcare system, have all created an environment that really breeds disparate health outcomes for Blacks. And it's really critical that we see our own biases so that we can learn from them, address them, and really tackle this head on. So, there's a lack of Black representation in radiation oncology, arguably medicine in general. Blacks make up 12% of the US population, but we only make up 6% of medical school populations. And the authors of this paper basically call anti-Black racism a critical systemic disease with sequelae that include police brutality, health disparities, educational and economic inequality, and also professional inequity. So it often comes up as like, what is the difference between inequality and equity? And I love this picture just because it makes it a little more concrete. Equality can be as simple as everybody having the same thing, same height to stand on. But is this really an equal experience for these three individuals? Whereas equity tries to kind of address some of the systemic underpinnings to make the opportunity more sustainable and more equal between individuals. So, I think another reason where this paper in particular, and I was just so proud of my field and my colleagues for really using their voice in such a powerful way. They actually addressed some of the recent deaths of Black Americans due to law enforcement. And, I'd encourage folks if they are, have time to kind of go through the slides to kind of read through this image and think about it, because obviously these individuals, these events affect us as individuals and affect me as a clinician, and as a mother, as a daughter, as a wife. So racial justice matters in Red Onc as well as in many other facets of our society. So what I love about the organizers of this conference is it's never just laying out the data and summarizing. It's call to action, like what can we do? So no, I'm not going to be able to rectify Black inequalities in cancer care in a 30-minute talk, but let's think about some solutions. I think discussions, so forums like this, extremely important and also very helpful. If during the course of this discussion, I'm able to pique the interest of just one person who maybe hadn't thought about things in this way, that'll be a huge success. I think workforce diversity is key, and there've been a number of studies kind of looking at this because particularly in vulnerable populations where there's some piece of mistrust with the medical profession, seeing physicians who look like you is so important. Just like when I was a med student in undergrad and elementary school student even, seeing mentors who looked more like me kind of encouraged me along the way to keep going on a really tough, arduous academic journey. I think it's important for us to know our history. And then the authors, Chapman et al. Of the Red Call to Action paper I mentioned, actually even point out specifically to radiation oncology some other more strategic approaches. So, you know, using this, ATIP principles, these are kind of concrete and somewhat radiation oncology specific, but definitely focus on acknowledgement of the issues at hand, transparency in, the data, integrating it into our professional society astro, intentionality in establishing a place for diversity, inclusion, and equity, and then also representation to really make sure that there is, strategic inclusivity. And the authors of the paper give concrete recommendations for astro, our professional body in radiation oncology, that I think are relatable and can extrapolate to kind of larger cancer care groups and organizations. And I've tried to implement some of these kind of, at a more micro level in my practice and in my cancer center. Another paradigm is the LEADS model. So learn, engage, advocate, defend, support. And this is another paradigm to kind of approach reducing anti-Black racism in radiation oncology. But again, I think a lot of these principles similarly can be extrapolated to cancer care in general and medicine in general. So, educating oneself about implicit bias and structural and systemic racisms, and encouraging faculty and staff to continue education efforts to really address these things. Engaging with our patients and our colleagues, asking how are they coping. I think asking those difficult questions rather than avoiding the issue or approaching it with, awkwardness is so much more important. And then concretely looking at things like reviewing pay scales, compensation packages to ensure that there is equity in our workforce and making corrections where needed. Advocating, so lobbying for equitable healthcare reform, voting. Voting is so important. Defending. So it's important for us to use our voice, and it's important to have allies who will also stand up against microaggressions and macroaggressions. And the importance of allies can't be understated enough, especially if we're trying to have true, meaningful social change. And then the importance of support. And again, I'd encourage anyone kind of listening to this talk who feels so moved to kind of read through this and see how some of the changes and suggestions kind of listed here can be applied to their own institution, their own practice. Other kind of, thinking more broadly of cancer care in general and some of the mortality data I showed, how about maybe mandating that federally funded clinical trials need to include a certain proportion of minority representation? Interestingly, this is a census year and our population is increasingly more diverse. And yet our cancer clinical trials unfortunately have really poor representation of underrepresented minority patients. So study protocols really should try to carefully document target communities and try to engage culturally appropriate recruitment and retention strategies to try to make sure that our research is more reflective of the populations we aim to serve. This just kind of is a matrix that walks through some of the strengths and weaknesses of these approaches, but I think as a cancer doctor in the clinics, I think especially, taking this a step further when it comes to cancer research would be really important to see if we can improve access to care. And another policy change that's another, possible solution, I think, would be to mandate something like a community resource center be necessary if you're going to have an affiliation as part of the National Comprehensive Cancer Network certification. So, now freestanding clinics and clinical ambassadors have to have 3 key functions. So things like patient education programs, patient navigator systems, and career development training programs. So I think making this more focused on racial equality can definitely help improve some of our workforce diversity issues and also some of our strategic programming in our communities that are more diverse. Obviously, there can be limitations, and I've listed some of these here. This is from a presentation, actually, that was part of a discussion with our cancer center leadership. So I encourage folks to really try to take some of these principles to their institutions and see how you, even if it's just on your clinic day, can try to understand some of these principles and be an ally of the struggle. So I want to end with this figure because I think it nicely sums up kind of some of the different principles that kind of come up in a discussion like this. We all have a intuitive understanding of what inequality is. And, I think while it's a very important step to address equality, um, evenly distributing tools and assistance, does that really fix the problem? Next level is equity, and we talk about health inequities and trying to kind of strategically modify our improvements to make sure that we're um, giving people the most help we can. But does that truly fix the problem? And I think it's important to have discussions like these and platforms and conferences like this as we try to truly move to a system of justice, which will require a lot of innovation and self-reflection and critical thinking to hopefully be able to be the change that we really hope to see in the world, and um, come together to try to make this world a better place for the next generation. So thanks all.